Start the presentation now. Meanwhile, other participants will be joining in. I'm Dr. Sadaf Mushtaq. I'm currently practicing as anesthesia consultant at National Hospital and Medical Center. And I'm also a fellow of pain medicine. And today we'll be discussing myofascial pain syndrome. Myofascial pain syndrome is a musculoskeletal pain condition characterized by local and muscle-referred pain perceived as deep, dull, pressure, and pain, and by the presence of myofascial trigger points in any part of the body. The prevalence of myofascial pain syndrome among patients presenting to medical clinics due to pain ranges anywhere from 30 to 93%, as only very few studies have investigated the prevalence or incidence of myofascial trigger points so far in general population. No local data is available, but one of the study was conducted in Karachi, and they observed the frequency of myofascial trigger points in upper trapezius muscle and its associating factors among the physical therapists in Karachi. Now, what's the impact of this myofascial pain syndrome? As we all know that myofascial pain syndrome is a musculoskeletal condition. And according to the global fact sheet, the painful musculoskeletal conditions are the leading cause of disability globally. And what's the pathophysiology of this myofascial trigger points? So far, it is incompletely understood. But certain hypotheses have been proposed regarding the pathophysiology of this myofascial pain syndrome. One hypothesis suggested that trigger points, which are the hallmark of the myofascial pain syndrome, are due to the dysfunction of the neuromuscular junction and surrounding connective tissue. Electromyographic studies have also revealed some evidence of abnormal electrical activity at the motor and plates of neurons terminating on muscle fibers of trigger points. Excessive electrical activity was identified as excess acetylcholine was released. The electrical dysfunction and the excess acetylcholine release both propose the possible mechanism for the formation of trigger points and the development of myofascial pain syndrome. Another hypothesis was introduced by the Simon. This is called as the integrated trigger hypothesis, which describe a possible consequence leading to the development of the myofascial trigger points, which are the hallmark of the myofascial pain syndromes. It proposed that the sequence of events was initiated by the local injury due to the repetitive microtrauma, which leads to the energy crisis. This energy crisis then actually initiate in this energy crisis that called for the initial prolongation of the contraction of the muscle fibers near an abnormal motor end plate. This would lead to the excessive release of the acetylcholine and sustained sarcomere contracture, which would lead to increased metabolic demand and compress the capillaries. Now, what is happening here? There is increased injury of the muscle due to any reason, which results in the increased acetylcholine and increased contraction of the muscle. This, because of the increased acetylcholine release and the increased muscle demand, there is also the decreased capillary supply, which results in the formation of the trigger points. The continued contraction with prompt this formation of the myofascial trigger points results in the muscle contraction, which provoke the inflammation by release of the histamine and bradykinins, leading to an inflammatory cascade of cytokines, leukotrienes, and substance P, which further release the substance P in the dorsal horn, leading to the central sensitization of the muscle, and this starts the vicious cycle. Now, which muscles can be affected by this myofascial pain? Not counting the heads and the bellies and the other divisions of the muscle, but according to the International Anatomical Nomenclature Committee, there are 200 paired muscles or a total of 400 muscle pairs. and they are not counting the muscles of the head and bellies in these muscles. And these myofascial trigger points can develop in any of the muscles. So you can find the trigger points or myofascial pain syndrome in any region of the body. This is a long list of muscles where we can find the myofascial pain syndrome or where we can find the trigger points. Starting from the head and neck, we can find the myofascial trigger points in the posterior cervical chain, in the sternocleidomastoid, upper trapezius, facial muscle. We can find these trigger points in the shoulder, trapezius, supraspinatus, infraspinatus, and then comes the chest and the abdomen and the lower back, pelvis, hip, knees. Even we can see the myofascial trigger points in the vastus medialis and latialis, and in the ankle and feet, so and in anywhere. So this is a long list. So what causes the myofascial pain? They can be primary because of the direct trauma to the muscle, or it can be secondary due to the other acute or chronic painful musculoskeletal conditions like head and neck pain, for example, pain in the TM joint, cervical degenerative disc disease, cervical facet arthropathies or neck pains due to whiplash injuries or cervicobrachial syndromes. It can be because of the thoracolumbar back pain. It can be because of the pelvic pain, because of the pain due to the endometriosis, and it can be because of the upper and lower extremity pain. The myofascial trigger points are associated with several painful conditions like migraine, tension type headache, TM joint disorders, mechanical neck pain, whiplash injuries, shoulder pains, carpal tunnel syndrome, low back pain, pelvic pain, knee pain, plantar heel pain, cervical and lumbar radiculopathy, and they can even be present with fibromyalgia syndrome. Even these trigger points were identified in cancer survivors of head and neck patients. So what are the clinical features? Trigger points characteristically elicit the referred pain, which can be stimulated, and when they are stimulated, the duration is variable. It can last for seconds, hours, or days. These referred pain is perceived as a deep pain, dull pain, burning pain, and sometimes it can be perceived as superficial pain. They can spread caudally or cranially, and this referred pain, the intensity of this referred pain is depends on the degree of the trigger point activity. What is the diagnostic criteria for this? There is the confirmatory diagnostic criteria for trigger points is still under debate, but there are three minimum clinical diagnostic criteria. Number one is the presence of palpable taut bands within the skeletal muscle. Number two, the presence of hypersensitive spot within the taut band. And number three, the reproduction of a referred pain sensation with stimulation of the spot. There are 6 confirmatory criteria, which are the presence of local twitch response with snapping palpation of the taut band, presence of a jump sign, patient recognition of the elicited pain, predicted referred pain patterns, muscle weakness or muscle tightness, pain with stretching or contraction of the affected muscle. Now, what are these tiny trigger points, which are actually causing this myofascial pain syndrome? The trigger point is identified as a hyper-irritable spot in the skeletal muscle, which is associated with hypersensitivity when we palpate the muscle, and which is also associated with hypersensitive palpable nodule in a taut band. This is a trigger point complex. Here you can see 2 trigger points. One is a small active trigger point, which is causing a local pain. But when this trigger point becomes enlarged and it involves a larger area, it can cause a referred pain. There are certain silent or latent trigger points in the body. Studies have shown that up to 45 to 55% of the young population, they have latent myofascial trigger points. And these trigger points, where they can be activated by certain trauma or stress or certain factors. Now, what are these precipitating factors which can convert these latent myofascial trigger points in active trigger points? This is a long list of, which shows, this is a long list of factors which can actually activate the latent trigger points into the active trigger points. It includes certain vitamin deficiencies, sleep disturbances, poor posturing, joint problems, chronic infections, inflammations, depression, certain metabolic disorders like hypothyroidism, hyperuricemia, and hypoglycemia. Now, what is this neuropathic myofascial pain? This is a normal muscle. What happens that increased acetylcholine receptor throughout this muscle causes the contraction of this muscle. This is a super sensitive muscle which overreacts to a wide variety of chemical and physical inputs, including the stretch and the pressure. Furthermore, they have a low threshold to acetylcholine, which is itself increased from reduced level of acetylcholine esterase. Acetylcholine slowly depolarizes supersensitive muscle membrane, and it induces the electromechanical coupling in which tension develops slowly without the generating action potential. In normal muscle, the acetylcholine acts only at receptors. These are the receptors, and acetylcholine is acting only on these receptors. But in this muscle, the acetylcholine is acting on the whole of this muscle. This is resulting in the shortening of this muscle. Now, what happens when the muscle shortens? This shortening of the muscle creates tension in the tendons and their attachments, which can cause tendonitis, tenosynovitis, chondromalacia, and even it can cause epicondylitis. This compression is also been seen in patients who have the shortening of paraspinous muscle. This is a normal disc. This is a normal muscle. Now, in this case, there is a shortening of this muscle. Due to shortening of this muscle, it is causing compression on this disc, and this disc is now compressing the nerve. And this patient is now presenting with the radicular symptoms. There are certain pain syndromes which are caused by shortening of the muscles, like frozen shoulder. In this frozen shoulder, all the muscles of the shoulders are shortened. In patella pain syndrome, quadriceps femoris muscle, these are shortened. Facet syndrome, muscle across the facet joint, they can be short. Headache, we can see the shortening of frontalis, temporalis, vertex occipital muscle. Even the trapezius, sternocleidomastoid, mastoid, temporalis, and suboccipital muscles, they can be shortened. And low back pain because of the shortening of the paraspinous muscles. Now, how can we diagnose this? The diagnosis is only in the presence of the active trigger points, which can be identified by palpation with gentle digital pressure, cross and perpendicular to the muscle fibers. Trigger points are present in a taut muscle band within the skeletal muscle, and palpation of these points may elicit involuntary muscle contraction, the twitch response, or the typical classical feature, that is a jump sign. So जब भी इसके ऊपर प्रेशर देंगे या करेंगे तो वो जंप साइन या ट्विच साइन से वो पॉजिटिव आएगा इन पेशेंट्स में. There is no lab investigation which is required for it, but on ultrasound we can see the trigger points. Now, what is the treatment? A systematic, comprehensive, multidisciplinary approach should be followed, which includes the physical modalities. This includes the ultrasound therapy, the stretch and spray therapies, the massage, the acupuncture, TENS, and laser. Occupational therapies, which includes the postural and ergonomic corrections, and the psychological therapies, which includes the counseling for coping strategies and relaxation techniques. What are the pharmacotherapies? With the drugs that can be given in these, we can go for the topical ointment like capsaicin creams, lignocaines, diclofenac sodium. They can be applied either in the form of cream or as a patch. NSAIDs or weak opioids, they can be given orally. Tricyclic antidepressants, amitriptyline has been found effective in patients with chronic tension headaches and chronic pain associated with TM joint disorders, and the muscle relaxants like actropanic, tizanidine, clonazepam, and other benzodiazepines and orphanedrines. They have the role in treatment of the active myofascial pain syndrome. Trigger point injections are for refractory myofascial pain syndromes. These are for those patients who are not responding to the conventional therapies like the physical therapies that we have recommended and discussed, and the oral therapies, pharmacotherapies. For those patients, we'll go for the trigger point injections. Dry needling can be done, needling with local anesthetic and steroids can be done, and nowadays Botox is being used. According to the International Association for Study of Pain, the massage, ischemic compression, pressure release, and other soft tissue interventions, they have moderately strong evidence for immediate pain relief. The laser therapy showed the strong evidence of effectiveness for pain relief. TENS and magnet therapy shows the moderate evidence for immediate effects of trigger points. Stretching, strengthening, and coordination exercises, they have the moderate benefit. Ultrasound therapy have the weak evidence for effectiveness in management of trigger points. Bright needling, however, they show the clinical benefit for the short term, but more studies are required. So we can summarize it like this, that myofascial pain syndrome is characterized by localized taut bands in the skeletal muscles and in the fascia. They happen or they develop because of the excessive leakage of the acetylcholine and dysfunction of the motor end plates. Myofascial pain syndromes can often be refractory to treatment. So a holistic approach which blends the basic clinical care with the management of biopsychosocial model is essential to patients with myofascial pain syndrome to regain their function and improve their quality of life and well-being. Exercise, posture correction, and vitamin balance in the diet, especially in vitamin B complex, appear to prevent trigger points activation. Thank you very much. And I would like to thank you. I'm especially grateful to Professor Dr. Khaleel who helped me a lot in preparing this presentation. And I am extremely thankful to STSP for providing us this platform where we can share our knowledge and we can seek more from our seniors. That's all from my side. So do we have any question or comments?
Thank you, Dr. Sadaf. It was a good presentation, of course. Here you had mentioned my name, so I can't say it was a good presentation. Anyway, it looked good to me as well. So, very well explained the pathology, physiology, symptoms, and treatment. And my experience is quite common. Quite common. Many patients' complaints are related to the musculoskeletal system, and many patients, even carpal tunnel, psychoretinopathy, they end up in myofascial pain diagnosis and are treated well with trigger point injection.
Thank you very much, sir. I would request other worthy seniors to please share their personal experience, how they deal with myofascial pain syndromes.
Dr. Sadaf, thank you. Can you see a question in the inbox there? So, one of the audience has put a question there. If you can read it.
Yes, sir. Now I can read the questions. Any role of ultrasound guide and dosage? I'm not getting the question. Role of ultrasound guidance in diagnosing or while treating the patient, or ultrasound in giving the physical modalities. I'm not sure what I'm trying to ask. Can anybody elaborate this?
Actually, I want to ask any ultrasound guided injections and the different doses, especially the Botox doses.
ओके लिटरेचर अभी तक मैंने देखा है, इसमें अल्ट्रासाउंड गाइडेंस में सिर्फ एडिशनल बेनिफिट इज देयर आर लेस चांसेस ऑफ कॉम्प्लिकेशन लाइक pneumothorax and other brachiotaxis injury, especially when you are giving the injections in the trapezius and neck. लेकिन बाकी ये कि डोजेज अभी कोई डेफिनेटली किसी भी लिटरेचर में डॉक्टर मल्टीपल स्टडीज हो चुकी हैं, सेलाइन को, कॉर्टिकोस्टेरॉइड्स को, लोकल एनेस्थेटिक को, लिग्नोकेन, ब्यूटिकेन, बोटॉक्स सबको यूज किया गया है। डेफिनेटिव जो एविडेंस है वो कहता है कि फायदा जो है वो किसी ड्रग का सिर्फ जो फायदा है वो सबसे पहले है ड्राई निकलिंग का, और जो हम ड्रग भी दे रहे हैं या सेलाइन दे रहे हैं या स्टीरॉइड दे रहे हैं उसमें फायदा है तो उनकी मैकेनिकल इफेक्ट का ज्यादा फायदा आता है। बाकी बोटॉक्स के ऊपर अभी स्टडीज हो रही हैं और लेकिन कहते हैं कि जो रिफ्रैक्टरी एज फार एज माय नॉलेज इज कंसर्न, जितना जो रिफ्रैक्टरी मायोफेशियल पेन सिंड्रोम है उसके लिए बोटॉक्स को रखें, क्योंकि उसमें कॉस्ट इफेक्टिवनेस बहुत ज्यादा आ जाती है और इंजेक्शन जो है वो आपको एवरी 4 to 6 वीक्स रिपीट करने पड़ते हैं। बाकी बोटॉक्स की वो 10 यूनिट्स या 20 यूनिट्स जो है उसके पॉइंट्स होते हैं डिफरेंट, जिस भी जगह पे आपने इंजेक्ट करना होता है वो उसके स्पेशली आप अपनी साइट्स मार्क कर लेते हैं और 20 यूनिट्स या 10 यूनिट्स जो है वो हर जगह पे लगा देते हैं। ये 100 यूनिट या 200 यूनिट की ऑयल आती है, उसको इंसुलिन सिरिंज में बना के तो बिल्कुल जो 2 यूनिट्स 20 यूनिट्स जो है दो बिल्कुल जो निशान है वो आप हर पॉइंट पे अपने मार्क कर लेते हैं। बाकी अगर कोई और सीनियर इसमें अपना कुछ ऐड ऑन करना चाहे तो प्लीज। Dr. Shahid, I hope I answered your question. Do we have any comment on this question?
Yes, I also agree with you. The Botox का experience हमारा भी बहुत ज़्यादा अच्छा नहीं है। पेन क्लिनिक पे बहरहाल इंजेक्टेबल जो आप डोजेज हैं उससे पेशेंट को काफ़ी रिस्पांस मिलता है। ड्राई नीडलिंग डेफिनेटली ज़्यादा हेल्प करती है। हमारा भी यही जो लिमिटेड एक्सपोजर है, बहुत ज़्यादा एक्सपोजर तो नहीं है, लेकिन ड्राई नीडलिंग कुछ पेशेंट्स को हमने की है वो डेफिनेटली ज़्यादा इफेक्टिव है और बाकी फिजियोथेरेपी वो ज़्यादा इफेक्टिव है। बाकी बोटॉक्स का हमारा भी बहुत अच्छा एक्सपीरियंस नहीं है इसके लिए।
Dr. Sadaf, Dr. Atik here. Can I add on in respect of the ultrasound here and the trigger point injections?
Yes, sir, please.
So I think the importance of ultrasound comes specifically in case of the high BMI patients where you are doing the trigger point injections. So with the ultrasound, you can really, make sure like you're injecting into the muscles. Because in the high BMI patients, you're not really sure like the layers of the fat and the subcutaneous tissue where you are injecting. I think so that make a difference there specifically. And even the patients who have a normal BMI, just for the assurance that's with the ultrasound, you are on the target. And as more and more it's coming into the practice, it may be the gold standard even for the trigger points. We will be using the ultrasound in a routine practice.
Thank you very much, sir, for your valuable feedback. Do we have any other questions or comments? If we don't have any queries or comments, so I think we can close the session now. Thank you very much, everyone, for being so patient and for your feedback.
Thank you, Dr. Thank you very much.
Thank you, sir.